What we hope to cover today is to briefly look at increased longevity in people with intellectual disability, and of course the implications that longevity has in relation to service provision for all the organisations throughout Ireland. We are also going to recap on the high risk of dementia, particularly in those people with Down syndrome, and the complexities and the essential prerequisites to support people with dementia. And we will share with you going forward a case study drawn from the Daughters of Charity Disability Support Service, where we have extensive experience in supporting people with dementia over many years. And we will share with you our experience in developing a comprehensive strategic plan and an action plan for dementia, which was supported at that time by Professor Mary McCarran to examine what were the essential prerequisites for ageing in place. So when it comes to looking at Down syndrome and life expectancy, we can see here the exponential rise in life expectancy for people with Down syndrome. And this is really something to be celebrated. At the Daughters of Charity Disability Support Service, we supported a lady last year with Down syndrome into her 80s. And this too is an amazing success story. However, accelerated aging and a longer lifespan places adults with Down syndrome at an increased risk of developing age-related health conditions. And despite improved survival rates, people with Down syndrome continue to experience atypical lifespan. So we have just said, aging with Down syndrome is a huge success story. And now there are real opportunities to promote lifelong health and well-being, to maintain independence, to reorientate all of our services, and indeed to mainstream the IG agenda. And this is a huge big issue for all of our organisations, because many of our group homes at the moment were set up for people who were able to get up in the morning, they were able to head off to their day service, go to work. And we never really planned in many ways that people were going to age. So now it's critically important in Ireland and throughout the world that we are trying to address and deal with these issues. How do we look at mainstreaming an ID agenda? We know that there are many high rates of morbidity and mortality, and we need to address health inequities that we often encounter, and particularly when it comes to dementia, with huge inequities for people with intellectual disability in accessing a timely diagnosis and the necessary post-diagnostic supports that are so important and so essential. When it comes to promoting well-being for people with Down syndrome, we need to do this through a quality of life lens. And I have said that longevity is increasing exponentially, and aging in poor health is an empty prize. And we need to ensure that people's physical health is good and that they have annual health checks. Social inclusion, this is so important, and that people are connected to their community, their families and friends. And we need to look at innovative ways to keep people with intellectual disabilities socially connected. And my colleague Pamela will touch on this later in this presentation. Personal development and lifelong learning too are so important. And we are now much more enlightened in terms of the importance of promoting brain health. And the recent Lancet Commission report has given us great insight how to keep our brains healthy. And this was the subject of last week's masterclass, and certainly keeping our brains mentally stimulated and activated is so important, and it's so important for the people we support. And we are using this model using a rights-based approach to care and self-determination. And here we need to understand the UN Convention of Human Rights, and particularly Article 6 and Article 19, and ensuring that people with intellectual disabilities are involved in decision-making as to how they would like to live their lives, and indeed how they would like to live their lives as they get older. And we can make those decisions with people when they are able to contribute to these discussions. And that means having these conversations much, much earlier than we're doing now, before they develop dementia, so that they can express their will and preference and how they wish to live. Looking at this slide, and many of you will be familiar with this slide, we can see the incidence of dementia compared to people with ID of other etiologies. We can see here that the yellow boxes represent the incidence of dementia in people with Down syndrome, and the blue boxes represent people with ID of other etiologies, while the red boxes represent the general population. And we can see here from Professor Andre Stridham's work that the incidence of dementia can be up to 5 times greater than in the general population. And people with Down syndrome are presenting with the clinical manifestations of dementia at a much earlier age. This slide is taken from Professor Mary McCarran's work in 2017, the 20-year longitudinal follow-up study that was carried out at the Daughters of Charity Disability Support Service. And I think what's really important with this slide is that you can clearly see the risk for developing dementia. This study noted a 23% risk for dementia at the age of 50 years. And 5 years later, the risk had almost doubled to 45% at 55 years. And as the person with Down syndrome is at 65 years, they have an 88% risk of dementia. And it's important to note that the prevalence of dementia in the general TILDA study in Ireland was between 4.3 and 8.3% for those over the age of 65. We also need to think about the health conditions that are very prevalent for people with Down syndrome and dementia. And I'm particularly talking here about new onset epilepsy. And here you can see the red line is the development of new onset seizure activity, and the blue line indicates the development of dementia over time. On this slide, you can see a linear relationship between the onset of dementia and the onset of epilepsy. And we now know that this often becomes a tipping effect for somebody being moved from their home because people actually haven't planned for this level of additional surveillance, additional supervision, and additional support that people with Down syndrome will require when they develop dementia and epilepsy. We have clear evidence now that almost 80% of people with Down syndrome and dementia will develop new onset seizures, and this compares to around 11% in the general population. And this is obviously very, very different. The concept of aging in place is a concept with multiple meanings. It implies the aging of people within familiar environments. It is based on numerous assumptions about the person's self-determination, least restrictive environment, the value of the home, and of course, quality of life. It gives us a sense of security, a sense of who we are, a sense of belonging, and this has a major impact on people's quality of life going forward. Home is a place not only where our heart is, but also where we have history and where our social connections are built, and that applies to each and every one of us. One of the big issues, of course, for people with Down syndrome when they move from their home, they can lose family, they can lose their home and everything that is important to them, their sense of connections, their community. And unlike the general population, most people with intellectual disability, as we know, are not married, they don't have children, they don't have grandchildren, and they don't have the critical social networks and supports that are so important to aging. So if they do move to a nursing home without these supports and the connections with the ID services are lost, and we have seen this many, many times, despite the best intentions, when somebody moves to a nursing home, we see a melting away of previous relationships. Yet people visit initially, but this wanes, and Professor McCarran has produced extensive research to speak about this both in ID populations and in the general populations in a lot of the dementia literature. For people with ID particularly, moving at a time when they are struggling to make sense of the world, lost in what's happening to them, which is very frightening and concerning time to anybody who develops memory problems. So in the broader sense, aging in place can be considered as not only a physical home, but the local community and social circles and networks where people also have a place. If people do have a sense of place within their home, social networks and local community, where possible, keeping people within or connected to this place is likely to improve their quality of life as they age. And this will be discussed further by Pamela later. The Wasted Lives report was launched by the Ombudsman recently, and this report raised concerns over very high numbers of people within the nursing home sector with a disability, many of whom were younger people, not necessarily with an intellectual disability. But in many ways, they are the voice of people with intellectual disability. These moves happened because services did not have structures in place to support safe care practices. And I would encourage people to read this document and to absorb the findings from it. It's really important because many people with intellectual disabilities who are in nursing homes may lack a voice. And this is so important. In the report, the Ombudsman reported that the inappropriate placement of a young person represented institutional care. So looking at the Daughters of Charity Disability Support Service and some of the lessons we have learned and how we have tried to manage ageing in place in this organisation. And one of the key things that we have learned is that these are the key questions to consider when supporting an ageing population. And we can all adapt these throughout organisations throughout the country. When you look at the demographics of your population and think about the slide I produced earlier on risk and certain ages, how many people in group homes, if you were to consider that age risk and project the numbers that are going to develop dementia in the next 5, 10 and 15 years, and what is the character of those group homes going to look like? This is really important to know the mix of services needed and how they will change over time. What is the best location for services? That includes day services and residential services, and of course, support services. We need to be clear about what we are trying to achieve in the services we provide. We need to develop sustainable services. That is one thing at the Daughters of Charity that we particularly learned, with many of the houses being two-storey with limited downstairs facilities and limited accessible bathrooms. Looking at dementia-specific day programmes and residential programmes and the need to develop a strategic plan on dementia for your organisation is critically important. One of the key components to strategic planning is, of course, strategic analysis. And what is critical to the strategic planning process is a thorough strategic analysis. And as I said earlier, you need to do these projections. You need to plan what the character of your group's homes are and what they're going to look like going forward. Planners, however, often decide to plan only from what they know. This makes the planning process much less strategic and often based on guesswork. This slide here is based on Professor McCarran's work, which details a format that was used to conduct and develop the strategic plan at the Daughters of Charity. A very comprehensive concept mapping process was undertaken, and this looked at the development of a steering committee and work groups to support strategic planning preparation. We developed focal questions because we wanted to capture input from all the stakeholders, including, of course, people with intellectual disabilities, families, frontline carers, and people in management. We wanted input from everybody in the service to support a generation of ideas. So we knew the science, we knew the prevalence of dementia, and we also knew that what good post-diagnostic supports looked like. We needed to understand if we could align the proposed ideas and develop a purposeful and informed selection of action items, and that is what we did. So you need to plan for success. And just to recap on what I've discussed, we need to access the current state of the service and organisation. We need to develop a vision of where we want to go. We need to determine the gap between the current state and the vision that you are proposing. We need to set a direction and create a strategic business plan. We need, of course, to implement the plan and to evaluate the plan. And again, my colleague Pamela will talk about this in a while. These are the 5 steps that realise the strategic vision. We need to provide clearly defined purposes for the service with realistic goals and objectives and specified timeframes developed to reflect the service's capacity for implementation. We need to ensure effective communication of the vision and the goals to the stakeholders within the services. We need to plan, planning needs to be focused with focus on existing resources to advance the vision. We need to measure progress from an established baseline with data collection, communications, and continuous quality improvement mechanisms, because we know that quality is not static. Once you reach it, it's outdated. So it's constantly looking at the quality framework and then requiring efficiency and effectiveness in the design and the delivery of dementia related strategies. And now I'm going to hand you over to my colleague Pamela Dunn, who will present a little more detail on how we got with the implementation plan at the Daughters of Charity Disability Support Service. Thank you very much.
Good morning, everyone. Lovely to be here. So thank you, Evelyn. And as Evelyn said, I'm going to present on how we have got on with the implementation of the plan and to give you some practical examples of things that we have done to promote ageing in place. So Evelyn presented a very nice vision there on the Daughters of Charity. But as we all know, it's about making the vision a reality. Vision without action is merely a dream. Action without a vision just passes the time. But vision with action can change the world. So we really need to action the strategic plan that Evelyn has spoke about there. And so Evelyn has looked at this and she has talked about these focal questions. And there were 4 focal questions that staff were asked. So they were asked, what do you want that you don't have? So what do you want to achieve? What do you want that you already have? And this is really important to capture that, what staff are doing and to mark that. And so when we looked at those 2 points, we looked at that, and as Evelyn spoke, the suitable environment, and many of our housing staff was going to be suitable for people to age in place. You know, typically it was a 3-bedroom semi-attached house that wouldn't sustain a person as they aged. So it was looking at the environments that we had. It was very much part of that as well as looking at our staff and staff education. And so we set up a 4-day staff training program. And so all staff who are supporting persons with dementia are trained now. And so very much is about building a competent staff who are capable of supporting people as their dementia advances. And as Evelyn spoke about ageing in place and the importance of home and looking at ageing in place, both in the context of the home and in the broader context of the community, and the importance of relationships. And within care, we talk about person-centered care, but we very much talk about relationship-based care. And staff would have built very strong relationships over the years. So it's about understanding those relationships. And as Evelyn has said, when you pull those relationships away from people, the travesty that can occur, particularly for people with ID, who may not have the broader family sense that you or I would have in terms of partners, children, grandchildren to support. So it's looking at relationships. But it was important as well that we looked at what we want to avoid. And as Evelyn spoke there very much on that report, a very welcome report on wasted lives. We want to avoid transferring to general nursing homes. And so that report is very welcome. And then as we look at what we want to eliminate, and very much we want to eliminate crisis decision making at end of life, unplanned as people would advance in their dementia. And so we want to remove the crisis from all the situations. So this is a very important document, and what's quite surprising when we look at this document was it was created in 2003. So here we are many years later, and I think this document is as relevant today as it was when it was produced in 2003. And I think there are questions that we need to continuously ask ourselves. So we have two documents here. The Time for Action is Now and the Irish National Dementia Strategy. And both of these documents provide a roadmap as to how care should be delivered. Specifically, the Dementia Care Strategy references the need to care for people with early dementia, including people with ID in their community and in their homes. And all of the documents that have been produced espouse the criticalness of planning to allow people to age in their own home and in the community and home of their choice. So here in the Daughters of Charity, we are committed to supporting people with dementia to remain in their own homes for as long as is possible. And many people with dementia continue to live in their home with support from the multidisciplinary team for many years after diagnosis. Indeed, we have had many people who have lived until final days, and this really is our goal. But when it is no longer considered feasible to give care with safety or with comfort, a coordinated approach to transitioning to a higher support setting is vital. And this is something that again is mentioned in the National Dementia Strategy and in the framework from O'Shea. And what they speak to is not moving into large institutional settings, but looking at transferring to very structured, tailored environments that can reduce distress for people with dementia. And so as people are aging, and we look at building circles of support, and as people have a diagnosis of dementia. And so when we look at building circles of support, the very key circles closest to the person and the ones that sustain a person are those relationships with family and friends and staff. So this circle is a vital circle. It's a primary circle. And then as we move out to wider circles, we look at MDT support. So we look at support from the occupational therapist, the physiotherapist, the dementia nurse specialist, speech and language therapist, psychologist, the social worker, and indeed our colleagues, the doctors and pharmacists. And as our circle gets wider, we look at all of the community supports. We look at memory clinics, there are specialist memory clinics and generic memory clinics. There's the Public Health Nurse, the Alzheimer's Society, Family Carers Ireland. And as people progress in their dementia, they have access to palliative care services or volunteer organisations and lots of online web resources, including Dementia Understand Together. So it's really important that we know what service and supports are available and we know how to access these supports. It's also really important that we understand that each person's experience of dementia is as unique as their fingerprint, that each person's interaction with resources will be different. And so when we anticipate the challenges that people will have, and Evelyn has very much spoken to this before we talk about aging in place, and we have discussed this previously at previous webinars here, in previous masterclasses. And so we understand the progression of dementia and what are the common challenges. So if you want to support aging in place, you really need to have an understanding of the progression of dementia. So we know as dementia progresses that people will have increased difficulty, increasing difficulties with memory, thinking and orientation. As their dementia progresses, they will have increased dependence on all activities of daily living. There'll be difficulties with eating and drinking. In our communication styles will change. Evelyn has spoken about new onset seizure activity. We know that people have emotional and social behavioural changes, and for some people, these emotional and social behavioural changes can be quite distressing. And as dementia progresses, we have issues with incontinence and mobility. So we very much have an understanding and a picture of what dementia is like in general for people. And as we said, we know that each person will experience it differently. But we know then in planning ahead, and in the words of Ronan Smith, we look for plan for the probable, work for the possible, and hope for the future. So I think this is really important. So in planning ahead, it's important that we look at environmental modifications, and Evan has spoken about this, and the need to do this in a timely fashion. And so having the input from an occupational therapist in looking at simple house modifications in a timely manner is hugely important. Looking at the social environment, optimizing physical health, cognition, activity and well-being, but in planning ahead, looking at the resources needed to do that. And advanced care planning. And advanced care planning is a process of discussion and recording. It can take place over more than one conversation. It takes place over time. And the Irish Hospice Foundation have published quite a lot of literature to support us in that. And within the Daughters of Charity, we have developed standards of care. And these standards are our roadmap within the Daughters, and all staff at training are trained in using the dementia care standards. And they bring staff through all of the different, there's different chapters. There's chapters on supporting the person as dementia continues, and social connectedness and well-being, in communication. So all of these standards are very important, and within organisations to have an understanding. And these are available online for other organisations who want to use them. So I'm going to give you a case example of a supporting care in the community, and this is just one of our ladies. So Anne had her first baseline screening for dementia aged 40 years, and at the age of 48 years she was diagnosed with Alzheimer's type dementia. And Anne remained in her home, supported by her familiar staff with lots of family involvement. She experienced quite significant challenges, including negotiating the behavioural and psychological symptoms of dementia. And so for periods, she had quite a number of challenges, but she also experienced a lot of life events shared with those she loved. So she celebrated her 50th birthday in her local community, surrounded by a large group of family and friends. And then Anne was supported through the advanced stages of dementia in her home. And she passed away in her own bed at age 55 years, surrounded by family and staff. So what needs to happen to put all of those supports in place? We needed ongoing person-centered needs assessment. And in response to Anne's needs, we needed ongoing staff training. So these two are very much interlinked, is in looking at where Anne was at any moment in time and being able to respond to that. We also widened our circle of support as Anne's dementia progressed. So we had a wider input of MDT and from community involvement. We had the public health nurse, but we also had tier support from palliative care services in the community. And in a timely, when Anne's mobility changed, Anne had an upstairs bedroom, and when she was no longer able to use the upstairs bedroom, there was house modifications and a wet room. So that supported her to stay in place. And very much within this here, we had a very committed staff team who wanted it to happen, and a management team who wanted it to happen. So it was putting a vision into reality. So this is a sample of 12 of our residents living within community residential services. And really just, I suppose, what I wanted to show you within the profile range is we have people ranging here at different ends. This lady was 57 years of age with Down syndrome. She was diagnosed in 2008. At 12 years on, she is still living now at an advanced stage of dementia in her community home. We have a lady here, 64 years with Down syndrome. She was diagnosed 6 years ago. She is still living in her community home at advanced stage dementia. We have a lady here, 82 years. She has intellectual disability of other etiology. She is 6 years since her diagnosis. She is mid-stage. She has a lot of comorbid health problems. She has an increase in falls and frailty, but staff with support from the OT and the physiotherapist are still supporting her to age in her home. So this really, I just want to show us the variety of people who are being supported from mid-stage right through to an advanced stage. And what is important is, previously we thought that people may live 3 to 5, 6 years with the diagnosis of dementia. We're seeing people live, we have had one of our ladies has been more than 15 years since her diagnosis. So we have people living many years from the time of diagnosis with dementia. And it's really important to understand that from a strategic point of view when planning. And sometimes there are times when, despite our best efforts, the home can outstrip its capacity to give care with safety and with comfort. And the Doors of Charity, through a strategic plan, has given a commitment to the continued care of the individual within the organisation. And so during strategic planning in 2003, when we looked at that document that Professor McCarran created, there was no Willoughview and Meadowview. And so it was a vision that people would be able to be supported to age within the broader sense of aging in place, to age within their community. And so Willoughview and Meadowview were designed based on the principles of best practice in dementia environments. And they have won awards both for design and care home of the year. And as is envisaged within the dementia strategy, the importance of a dementia capable environment supported by staff who have the knowledge and skills to support care needs, complex care needs. And in a little while, we will show you a clip of Willoughview and Meadowview at the end of this presentation. So supporting care in the community, getting different perspectives. So we have the perspective of the person with intellectual disability. What's their perspective? And it's really important, as Evelyn said, to ascertain their will and preference. This is absolutely key, and it's key that we do that. It's important that we look at the value of relationships and the importance of sustaining them. But it's also important we get the perspective of the relative. Relatives attach huge importance to the person with ID being in their usual home with familiar family and friends. And it's really important, I suppose, to remember that family will have known these staff and peers within the house for a long period of time. And so they also have invested relationships within that. And then looking at the perspectives of the staff and health professional. And as I said earlier, that we really value relationship-based care, and staff have often built up very close bonds with the person over many years. So it's really important that we take all of these perspectives into account. And so when moving home, some important considerations. And as I said, absolutely what is key is the person's will and preference. And for some, if there is concern that somebody lost the capacity to make a decision, we now have guidance from the Assisted Decision-Making Capacity Act 2015. And so we can look at the person's past will and preferences, and we can look at that will and preference can often be demonstrated by words or behaviour or both. So ascertaining the person's will and preference is hugely important. Also looking at the person's emotional security. There are continuity of care, how we bridge that. Connectedness, how we keep the person connected to all that is important. We look at the expertise of the team and the environment, and is this dementia capable to support somebody to final days? And instead we're looking at respect for autonomy. So all of these are very key considerations. I have spoken before about life story and the value of life story, and I would just like to bring now the value of life story to supporting people through transitioning. So if we're talking about honouring personhood and knowing somebody, we really need to build up that understanding of who the person is. And so in a life story, we have a chance of gathering this information over long periods of time here on childhood, family, significant life events, and cataloguing this in a very visual way that brings the person very much to the fore. And this is a quote from somebody here within dementia: "It helps me to keep my memories." And this really is, as we have seen, it has been huge value to staff in getting to know somebody. So when somebody is no longer maybe verbal or mobile, that they can look back at video chapters and really get a sense of the person. And so life story is hugely important in transitioning. And so I'd like to just bring you through some of the important considerations in a transition plan. So in the Doors of Charity, we have a transition plan that if anybody's moving home, and that everybody would take part and complete this transition plan. And so we would start off, and this is done, as I said, over a long period of time. And so we look at who's the person's key support staff, both in residential and day services, who are their wider MDT, and we list them and we bring them all involved in the process. We look at family input into shared decision making and involving family, and so that's very much important. But we look at said promoting well-being and social connected. So we list who are my friends and what notified of my move. Who are all the important people in my life, in my day service, in my work, in my social connections, my Special Olympics. So if you were to stop and think of all the people you know, and you send out your Christmas card list to, it is gathering all of these people. And then we have visits to my new home. So then we would start, and very often the person would start to use respite, and they would come to start building a familiarity in the new home. So we would have visits to the new home and we'll show a bedroom in a moment, preparing a bedroom and making it home from home. But getting to know me, what we introduced was that the new key worker that they would become familiar with when they moved to the new home, that key worker then would go to spend time with them in their community home. So actually moving in to watch somebody in their community home and how they interact with people, what's important, and really those nuggets of information then can be brought back to the new specialist home that they are transferring. So this is really important, is that the key worker spending time in the community home. And then when it comes to the actual supported move, what we have put in place is that key support staff from their community home move with them. And so for a period of 5 to 7 days, they are supported by their familiar key support staff. And we find no matter how fantastic documents are, and we prepare transfer plans, word of mouth and actually the nuances of actually staff speaking to each other is really important. So this is quite an essential part, is in staff making the move with the person. But this has also had another benefit, in that it allows staff to become familiar in the new environment. And so visiting then doesn't become so strained, and that they become quite at home. And so what we would encourage when somebody moves into Willow and Meadowview is that a measure of how comfortable they are is that they feel at home to go and stick on the kettle when they walk in the door. So community staff and family feeling that they can go in, stick on the kettle and be part of this. So all of this comfort and familiarity is built up during the transition process. And so this is a bedroom. It says personalizing my room to reflect who I am. And as we see here, a box of Special Olympics medals gives a picture into so much of a life lived. So very much it's about personalizing a room, that the person is going from home to home, and that all of these important parts of a person's life are captured.
I'm going to start off with Kathy. Kathy, based on everything you've heard and your own experience, and when it comes to aging in place, you know, what do you feel is important for family and carers? What are the top 3 or 4 things that you think are really important for families and carers to consider?
I think it's really important to have an understanding of the stages of dementia and how it progresses, because we know that there will be changes at each stage, and the person's environmental needs are likely to change within each stage. And as Pamela and Evelyn talked about that need, I think the critical thing is to be discussing these issues early, so that we can really plan in advance, so that we're avoiding crisis situations. Because really, in my experience, it's been when those crisis situations have happened that we tend to see those moves out to perhaps out of the home. And that can be really upsetting then for the person and their family and carers. So I would say early planning, getting everybody's views on what they want for the future, and then engaging with the multidisciplinary team to look at the home environment. So I'm an occupational therapist. I can go in and assess the environment to look at what changes might be needed and to give advice on that. And then other professionals can also go in and give advice. But I think it's engaging early, having these conversations, and just avoiding those crisis situations.
Yeah, indeed. And I just remember working so closely with the OT at the particular time, and even those chairs, simple things like the chairs at the table, the meal times being the central hub, and having even simple things like pressure relieving cushions on the chairs.
Yeah.
People could sit there all day if they wished without having to be using rings and pressure sores. And we never have had a pressure sore in that dementia home for all of those years.
And I think it's looking at things like not only the physical environment, but the visual environment. So things like, can the person find the toilet easily in bathrooms? Often those rooms can get forgotten about, and as the person's dementia is progressing, they're finding it more difficult to navigate their way around spaces. So looking at those environmental cues that we can really lead somebody around an environment to where they need to go, and we can do that using color and paint. That there are often really simple solutions. I mean, one big thing I come across in a lot of residential homes is corridors being quite dark and dimly lit, and literally it's just a question of switching on a light can make such a difference to somebody. So often it's not that there are big changes that can be made, yes, but there are often smaller changes that cost nothing.
Yes, indeed. Absolutely. Thank you very much, Kathy. Pamela, from a speech and language therapist perspective, and we work very closely indeed at the Daughters, and we're very lucky to have a wonderful department there. What do you feel is how can the speech and language therapist support people as across the continuum of dementia, and some important work that you're involved in?
Right, thanks very much, Professor McCarran. Yeah, I mean, from a speech and language therapy point of view, we would very much support around two main areas. So around the communication, and then around the person's swallowing and their feeding issues as well. And I know next week's masterclass is going to kind of look a little bit more in relation to that side of things. But I guess when a person is verbal and in those early stages of dementia, if a person is verbal, again, it's about providing strategies to the individual and their families around word finding difficulties, looking at accessible information as well for the person with dementia, and providing them with information in an accessible way about their diagnosis, and to use visuals with them throughout the process as well, in relation to helping them understand. I'd be very heavily involved in terms of accessible information for people with intellectual disability. So again, starting that very early on will be very, very important for the person. And again, education and training for families, for staff, about the different strategies to use with the individual in relation to, removing distractions, speaking slowly, using a gentle voice, all those strategies that are really, really important for a person with dementia and intellectual disability.
Yeah, absolutely. And in terms then of end stage dementia, I know we're talking about nutrition next week and swallowing difficulties, but this certainly is often an issue. And the biggest issue that I've seen perhaps is even perhaps frontline care is not even recognizing that probably somebody is having swallow difficulties. You might want to just comment on that, Pamela.
Yes, definitely, Professor McCarran. Yeah, I would find that in my practice that there definitely needs to be a lot of ongoing training, and we certainly, with the Bird of the Charity in Roscommon, there'd be a lot of training with staff, around the symptoms and signs to look out for in relation to difficulties swallowing. Again, at those earlier stages, we're looking more at difficulties around perception and issues with recognizing cutlery and food, and ensuring that the mealtime environment is as least distractor for the person. But as we move forward, again, it's about towards the end stages, it is around modification of food and fluid in relation to ensuring that person is as safe as possible when they're feeding.
Yeah, and one of the things I think that both Pamela and Evelyn spoke about in the presentation was the criticalness of maintaining social connections, and and
Definitely.
maintaining that within the community. And Pamela, I'm just wondering if you can add anything to that conversation.
Certainly, yes. It's such a vital aspect for a person with intellectual disability and dementia, and in terms of their quality of life. Again, from a speech and language point of view, in relation to supporting that social connectedness and that involvement within a person's own community, again, would be very much using the likes of I know Pamela mentioned earlier on in relation to those memory books and those sort of visual supports that can be used with a person with intellectual disability and dementia to help start that conversation and to help engage that person and reminisce about things in their lives, which again helps that social connectedness for the individual. And again, using things like communication cue cards can also be useful for the person, and again helping them to maintain choice for as long as possible. As the person's condition develops, they may not be able to recognize pictures and photographs, so again bringing in the likes of your objects of reference where the person can still make a choice within things within their daily environment using real objects. So again, that choice making, that independence, and that autonomy is preserved for as long as possible. Excellent.
Fantastic. And I suppose one of the big concerns we have in Ireland, and I know from the multiple emails that I receive on a nearly a daily basis now, is the concern expressed by staff in terms of the movement of people perhaps with intellectual disability into a nursing home, and oftentimes very early on in the dementia. And I suppose one of the things that I know both Evelyn and Pamela, alluded to the most recent report that has come out. But one of the things I suppose that we need to caution against within the ID sector is that we don't roll back on what we have achieved with respect to decongregation. And we need to continue with decongregation and not start off a new model of decongregation. So I think that is really important. And, the books on deinstitutionalization, the final chapters for me are not written yet, because we need to see how successful we will have been in enabling people to continue to live in a home of their choice, in a community of their choice. I'm just wondering if there's anyone on the panel that would like to speak to that or comment on that. Kathy, do you want to add anything to that?
Yeah, I mean, from my own experience, I think there's a lot more conversations that have to be had between services and perhaps the HSE around supporting people to be able to live at home and to the end stages. I think there's a lot more work to be done. And I think seeing your report from 2003, that study, it really struck me as, I wonder how far along have we moved since then, and as you say, I think it's really, really important. We have to keep that conversation going, and look at how we're going to achieve that aspiration.
Yeah. Marianne, do you want to comment on that from your perspective?
Yes, hi, Professor McCarran. Yes, indeed. I think one of the things we have learned in the Brothers is the proactive strategic planning that Pamela and Evelyn mentioned is so important. Certainly, if you can go with a business case seeking funding to improve the lives of a number of people in one business case, and that's based on strategic planning, individualised person-centred care, but often you can have more success in getting funding if you can meet the needs of a number of people who are ageing in a very person-centred way. So there is a lot you can do, but there does need to be a lot of strategic planning by organisations well ahead of time, using the tools Evelyn and Pamela showed us today.
Yeah. Pamela, do you want to add anything to that, or Evelyn?
No, I think it's just as Marianne alluded to there, it's so important to plan. You fail to plan, you plan to fail. So planning is critically important. And we have found at the Doors to Charity service that our strategic plan has worked very well, because we included so many people in that planning process, from people with intellectual disability themselves, right through to frontline staff and indeed members of management. And everybody had input in guiding the strategic plan, which has proved to be very successful.
Yeah, I think the big issue is really, as we presented today, was having a vision. What are you trying to do? What type of service are you going to deliver? as you know, we have said, you know, what is the character of your group homes going to look like in the next 5 to 10 and 15 years? And are you planning to support people to age in the community? And if you are, how are you going to do it? And I think we have a fragmented system as well, and we need to look and share services and share resources across organisations, which are often almost tipping the margins of counties with each other, or areas with each other. So we need to open up, and we need to have a much more inclusive and sharing of ideas and sharing of resource model than we currently have. But we absolutely, I feel, with the deinstitutionalisation, we had a very clear philosophy that drove that. We had a very clear mandate to understand what we do. We've got drove that. I want to see that same type of a mandate now to drive successful aging and aging in place for people with ID over the next number of years. So I really do want to thank, and I think the like of the National Intellectual Disability Memory Clinic, and indeed this series of masterclasses, and we have our colleagues here, you know, who from the UK and other countries who are joining us, that we can really engage in that discourse and get a coalition of the willing to start those conversations. And I certainly think that things like COVID has shone a light on some of those issues in many ways. And I think the time is now and the time is right. And I'm really glad that we have had this masterclass this morning to start a discussion around the criticalness of aging in place and how are we going to support people who are aging. Because rest assured, we are dealing with dementia today, but as people age, it's not going to be which condition I'm going to get, but it's how many and in what combination. And because I'm entering that phase of my life, I'm very aware of all of these issues myself. So we really do need to plan for success and to plan. Not only do we want to add life years to life, but we really want to add life to years. And understanding how to support successful aging is key. I'm just going to finish it there.